Hi, everyone, and welcome to the Clinics Review Articles podcast series. I'm Taylor Hayes, the managing editor for Physician Assistant Clinics here at Elsevier. PA Clinics is a quarterly publication that provides deep insights into the latest advancements in the PA field. Our clinical review articles address the key points, diagnosis, prognosis, clinical management, and complications of disease and techniques, evidence, and controversies in the field. Joining me today is consulting editor Gerald Kayingo to lead the discussion.
Thank you so much for having me, Taylor. My name is Gerald Kayingo. I am the Robinson Endowed Professor in Health Professions and also the Executive Director for PARA here at the University of Maryland, Baltimore. I'm so happy to have one of our editors, Dr. Sandra Di Palma.
Thank you. It is wonderful to be here with you. Such an opportunity. I can tell you a little bit about myself and my background and how I got involved in this project. I've been a PA in cardiovascular medicine for over 20 years, have advanced certifications in lipid management and hypertension control. Really had a long career being involved in patient care and advocacy, and that advocacy then eventually led me to my current full-time role as Vice President of Reimbursement and Professional Practice with the American Academy of Physician Associates.
We are so happy to have you. I'm so excited to know that you have practiced both clinically, but also you've had the opportunity to see healthcare from a different side of reimbursement. So what a wonderful opportunity for us to have you. We're going to be focusing on two major questions today. One, we'll look at why is this issue of cardiovascular medicine important? And the two, we'll look at the role of PAs for managing heart diseases. And then we'll focus on a couple of chapters in the issue where we'd love to hear your personal insights. We'll be looking at social determinants of health. We'll look at hypertension. We'll look at what's new in the field of lipid disorders. And last but not least, we'll look at what does it look like to practice in cardiovascular medicine. Let's start with an overview of the series. So, Dr. Di Palma, could you give us some insights into what this series is about and what inspired you to participate?
I'd be happy to do that. I'm so passionate about cardiovascular disease and cardiovascular prevention. We know that cardiovascular disease is a leading cause of death for men and women in the United States. And there's actually one person in the US who dies of heart or vascular disease every 33 seconds. But it causes more than just increased mortality. It decreases quality of life for not only the patient, but for their family members. It contributes to disability. From an advocacy lens, it increases healthcare utilization and costs. But I think probably even more importantly is that there are very effective treatments. So we know the burden, but we also know that we can reduce that, whether it be treatments for the actual conditions themselves or for the risk factors that lead to cardiovascular disease, so that we can really prevent disease from even happening in the first place.
It's amazing that despite all the technological advancements we have seen in the last couple of years, cardiovascular diseases continue to be the leading cause of mortality and morbidity. And of course, like you said, the costs associated with heart disease are astronomical. So there are some populations here in the U.S. that are more affected than others. Minority racial groups, ethnic groups really see the huge burden in cardiovascular diseases. So I'm so glad that you actually highlighted that. So in addition to highlighting the role and the impact of heart diseases, we also want to know how can PAs make a difference? So Dr. Di Palma, can you highlight what roles PAs could play in alleviating this burden?
Absolutely. And I think there's such a strong role for PAs in this area. PAs regularly diagnose, treat, and prevent cardiovascular disease, whether that be working directly in cardiology or whether it be in primary care, internal medicine, specialty care. There's a lot of overlap with diabetes management, or even in perioperative management of patients with heart and vascular disease, knowing when you can stop anticoagulants to go into surgery. So it really is an area that spans many different subspecialties and where PAs can really contribute. I think our generalist training makes us very adept at being able to manage these diseases no matter what our primary specialty is.
Absolutely spot on. PAs, believe it or not, are the glue that holds the healthcare team together. Whether it's in primary care, whether it's in surgery, whether it's in inpatient, you're going to find PAs. And like you said, really, PAs are well positioned to be the game changer in this area of cardiovascular management. I love to hear that. Thank you. So now that we have had the role that PAs can play in this field of cardiovascular medicine, I just want to focus on a couple of chapters that stood out for you in this series. We're going to look at social determinants of health. Can you tell us a little bit more about how you felt about this chapter and what should an average PA know about social determinants of health when it comes to cardiovascular management?
Absolutely. So Camille Dyer wrote this article, Social Determinants of Health, Let's Get to the Heart of the Matter. She's been a longtime cardiovascular PA, very accomplished in that field, and very much an advocate for patients and PAs in cardiovascular medicine and in the general medical community as well. And we included this article about social determinants of health, health disparities, and racial inequities and how they influence cardiovascular disease. Unfortunately, as bad as the statistics are for the general population in cardiovascular burden, we know that burden is not distributed equally. There are certain racial and ethnic groups and geographic regions that have higher incidences of risks. And so we wanted to make sure that PAs were very much aware of these inequalities, but then also to help them address them and even improve the health outcomes of their patients. So we wanted to really bring this to the forefront of awareness and recognition.
Wonderful. And I think that is very consistent with the direction where our healthcare system is going. I think there is a very strong emphasis on health equity. There is a very strong emphasis on health system science, whereby we don't only talk about the biology of the disease, we don't only talk about the technology that is associated with the care, but also addressing all other aspects of care. The health disparities, health equity, the care, the quality, and all other system factors that really influence the care that individuals get. So I just can't agree with you more that there is a lot of, there are some minority racial and ethnic groups here in the US and even across the world that are disproportionately impacted by cardiovascular diseases. So more than ever before, I think it's important for PAs out there to appreciate that certain groups of people are more impacted than others and incorporate those facts of life in their treatment plans. Thank you, Dr. Deepama. So I really appreciated the inclusion of this chapter in this series, but let's focus on yet another important factor, and that's hypertension. We know this is one of the most common disorders affecting both men and women. So I want to hear a little bit more about the insights on hypertension.
Certainly happy to do so. And, this is a condition that really transcends various specialties. It's almost unavoidable in any area of practice. And I don't think clinicians always realize how prevalent and how impactful it is. There are statistics that show that nearly a half of all adults in the United States have hypertension. That's more than 120 million people. That's not even accounting for the fact that we're having younger pediatric patients experiencing hypertension. And at least among adults, unfortunately, more than 3 out of 4 do not have their blood pressure adequately controlled. And that contributes to cardiovascular disease, but also to kidney disease. Our nephrologist PAs are going to see that. Our ophthalmology PAs are going to see eye disease and so many other different conditions. Effective treatments are really out there and reduce the risk of all-cause mortality, morbidity, disability, and decreased quality of life. And so this is the article that I wrote within the series, and it's Hypertension, a primer on primary and secondary hypertension.
Hmm.
So it talks about both primary hypertension and secondary causes, how to help diagnose those and then treat them. And it talks about lifestyle modification, evidence-based medication, and even some emerging treatments that we're starting to see, like renal artery denervation, that PA should at least be aware of because their patients might be coming back to them from the specialist and hearing that this is a treatment option for them.
Hypertension is huge. Thank you so much for sharing that. You know, I'm a strong believer, Dr. Dipama, that food is medicine. I believe that a lot of chronic diseases that we see today could actually either be prevented or even improved just by using food. Do you have any insights about food is medicine when it comes to hypertension?
Absolutely. There's so much recognition and awareness that significantly contributes to either disease or to health and wellness. I think one of the nice things with cardiovascular guidelines in general is that they really emphasize dual modalities. So they recommend lifestyle modification that includes healthy foods, also exercise, abstaining from harmful habits. But then there's also the pharmacologic management as well. And a lot of evidence can show that you can get similar reductions in blood pressure, similar reductions in lipid management, which I think we'll be talking about next, but similar efficacy with diet and lifestyle as you can with medication. And then if you can put those two together, you can really effectively help a patient manage their disease.
So if I'm a PA out there taking care of my patients, in addition to giving them the lisinopril and other metoprolol and other medications, I should probably prescribe exercise and prescribe food. Is that right?
Absolutely. And there's evidence that when you actually make it a prescription, when you tell your patient that can be as effective as a prescribed medication, they're going to take that a little bit more seriously than if it's a weak recommendation. Also, I can say that in these articles, they give information for the risk reduction that you can see with those lifestyle management, with the healthy diet and exercise, so that you can use that evidence to help your patient understand that there's a benefit to engaging in those healthy lifestyles.
Thank you so much. And I think this is one of the key highlights for this issue, that it's not only focusing on pharmacological intervention, but it emphasizes the intersectionality between medicines and lifestyle factors. It emphasizes the intersectionality between health system science and social determinants of health. So it kind of brings everything together, that approach, that comprehensive approach, that integrative approach that is so critical for managing chronic diseases such as cardiovascular problems. So I really appreciate that. I also wanted to emphasize the point you made that hypertension is not only a problem for the heart. It goes far beyond the cardiovascular system to affect the kidneys as well. So as we are managing patients who have high blood pressure, it's so important for us to think about other professions as well, other specialties, think about referrals to ophthalmology, think about referrals to nephrology, quite frankly, even referrals to dermatology, because when you don't have a good heart, when your blood pressure is not good, the skin doesn't look good either. Is that right?
Absolutely. It affects all the other systems.
Wonderful. That was so exciting. So I'm going to move on to another topic that's very intimately related to cardiovascular disease, and that is the problems lipids. What's your take on that?
Dyslipidemia is a significant contributor to cardiovascular disease. About 50% of the overall risk of cardiovascular disease is associated with it. So we had Laura Ross, who is a lipid expert and a cardiology PA, write this article entitled Dyslipidemia. So it is very prevalent, as well as hypertension. And this is another risk factor condition that a large number of PAs are going to come across. Again, whether it be in cardiology itself, primary care, endocrinology. We know that other endocrine disorders can affect the lipid balance. medications that are prescribed in almost every specialty can have some influence on lipid parameters. And this is another area where I think it's important to know that it's more than just identifying the condition. There are so many things that we can do to lower the risk. So it's not just lowering the numbers, it's lowering the risk that had been associated with them. We talked about non-pharmacologic management. This article does talk about all of that, diet, lifestyle, how to be preventive. And then it does talk about pharmacologic interventions because we know that those are a mainstay as well. Statins are really the frontline therapy, but there are newer medications that are really highly effective, and this article covers that. Also, this article summarizes the most recent national treatment guidelines. The hypertension one does as well. But I think PAs would be interested to know, and they may not realize this, that there were PAs involved in writing both the cholesterol guidelines and the hypertension management guidelines. So PAs were integral in actually developing the guidelines that other PAs are going to be following.
And so it was also nice for me to learn as I was going through this issue that this age at which we are starting to screen for lipid disorders has over the time changed. I mean, when I was going to PA school, we thought about the 45-year-old, the 50-year-old. But given the changes in the metabolic health, I see that the guidelines are now getting younger and younger. Is that right?
It absolutely is. We also have a better understanding not only of the fact that, as you mentioned, metabolic conditions are different than they maybe were 10 or 20 years ago, but we also look at lifetime risk of an individual and not just a 5-year or a 10-year risk. And so we know that we can really halt disease progression if we're able to identify it early. There's also talk in this article about familial hypercholesterolemia. That's a genetic inherited disorder. And there's first-line screening recommendations. If you find an individual in a family that has that condition, you'd want to screen even much younger in childhood, because if they have this lipid disorder that contributes to very, very high levels of cholesterol, you can make a significant difference and postpone their having cardiovascular diseases by 10, 20, 30 years. We've just got so effective medication at this point and well-tolerated medications.
Wow, that's so great to hear. I think when you talk about the healthcare team regarding cardiovascular diseases, we traditionally think about, hey, the cardiologist or the nephrologist. But what I'm hearing, that also including the cardiovascular genetics is actually an important member of the team so that they can help you, especially when there's some of those genetic disorders involved. Is that correct?
It is. Geneticists are very closely involved, whether it be in lipid or some different type of hypertension conditions, involved in pediatric as well as congenital heart disease. We see that. And cardiology is a really fascinating field in which they've been very embracive of the cardiovascular team. It's one of the reasons I've liked it so much. And that's beyond even the traditional practitioners. There's pharmacists that are involved in helping patients manage their medications. They've now started to involve psychologists. They realize that people can have post-traumatic stress disorder from having a heart attack, or have adjustment disorders, especially in congenital heart disease. Patients are pediatric or teenagers and are going through body image with their scars. So they've really embraced this more diverse management and treatment than just the traditional physician or even the traditional clinician.
Interesting. Actually, talking about a healthcare team, I'm so glad you talked about depression and so forth. We know that almost every patient who has chronic disease, take an example of heart failure, there is always the comorbidity of depression. So I would definitely recommend that if you are patients who are out there are struggling with heart failure, refer them to a psychologist or do even the simple screening for depression. That would help them be able to get motivated and actually take the medicine and even take the recommendations that you do provide for the cardiovascular condition. Thank you. So it was so nice to hear from you, Dr. Deepama, talk about the genetics, as a confounding factor for these conditions. But also there have been some new knowledge talking about things like infectious disease. So we now know that COVID-19 alone is also a risk factor for cardiovascular complications. Do you have any take on that?
Certainly, and there is an article on that. It was written by 3 PAs at an academic medical center that were seeing a lot of cardiovascular conditions. It really can affect the vascular biology and affect the pathophysiology of the arterial system, and that can contribute to diseases. I think we're still at the early stages of understanding what the long-term consequences could be. We also know that people had problems with thrombosis, so whether that could eventually affect pulmonary arteries that might have been occluded. I think it's going to be an evolving area where we're going to find out more over the next 5 to 10 years. But we certainly have an article that talks about what we know in the early stages coming out of the pandemic of COVID-19.
So you remember those days when we were in PA school and they were teaching us and how to take a history and how to do a physics exam. I think in this era, it's so critical for PAs out there to ask those questions. Did you have COVID? Do you have longer COVID? So that as you were planning and putting together a treatment plan, you uncover some of those answers that may be missed because critically, they would influence the outcomes of the treatment plan. So let's now go back. Since PA Clinics is focused on PAs, by PAs, let's go back to revisit the role of PAs in cardiology, particularly looking at what does it look like to be a cardiology PA?
There are about 3% of PAs who practice in cardiology. I know that seems like a relatively small percentage, but it's actually the most prevalent internal medicine subspecialty for PAs. And I think that has a lot to do with the nature of the work and the environment that it's drawing PAs. Very flexible, whether you want to be working in general cardiology or you want to specialize. I have advanced certifications I mentioned in hypertension and lipid management. So there are PAs who are running their own lipid clinics or resistant hypertension clinics, whether that be within a cardiology practice or a primary care practice. There are PAs who are getting specialized in electrophysiology. There's congenital and pediatric cardiology, structural heart disease. There are so many new minimally invasive procedures that are involved in cardiology that PAs can be a part of. Cardio-oncology is a new evolving opportunity. Unfortunately, a lot of the chemotherapeutics can have cardiac effects, and so they need a multidisciplinary team. PAs are well suited to that, as we mentioned, that they're generalists and can really pull together different specialties and provide that patient-centric care that's needed. And then there's CT and vascular surgery, which are closely related. So there's really endless possibilities, and that can be inpatient, outpatient, a combination, pediatric, older patients, whatever the PA has an interest in. I think it's also a very rewarding field. You get to feel that you make a difference in patients' lives. And it's an area where they've really embraced PAs and they've really embraced team-based care. And I recently did an article, some research with NCCPA, and we found that PAs in cardiology have higher job satisfaction and fewer symptoms of burnout than the average PA. Probably for various reasons, but I think it has to do with the reward that you get from that job and the environment that you're in. So it's really just a great area of medicine for PAs. You can really feel like you make a difference, and that can be, just that individual patient in a small town, or it can be nationwide, working on different initiatives with the cardiology organizations.
So it looks like every single personality can find some niche in the cardiology. If you're somebody who is more of hands-on type of a person, you can be in the procedural side of cardiology. If you're somebody who is just love internal medicine, you're not too big into procedures, you can either go in the preventative cardiology or outpatient cardiology. If you're somebody like me who loves adults and the geriatric population, again, you have a home in cardiology. If you are somebody who loves younger people, you can go in pediatric cardiology. So it's like the home for everybody.
I was just going to say that it's something for everyone. Absolutely.
Yeah, love to hear that. Dr. Dipama, we cannot finish this series without acknowledging the rapid growth of technologies We are now talking about artificial intelligence. We are talking about precision medicine. We are talking about genetics, monoclonal antibodies, and so forth. How do you see artificial intelligence and other technologies influencing the way we take care of patients in the cardiology field?
I think we're going to see changes. But I think the one thing that's been interesting to think about is that cardiology has always been on the cusp of technology. When I started in cardiology, I'm going to date myself, but 22 to 25 years ago, at that time it was felt to be cutting edge, and it's stayed that way. So we've always been an area that has embraced new technology, new ways of doing things, which makes it nice that you know that if we don't have something now for our patients, we're likely going to have it within the next few years. So that's always been something that's been embraced by the cardiovascular community. I think we're definitely going to see more precision medicine. Although we already have a lot of point of care apps and tools that, we probably didn't even think that they were AI at the time, but had some AI components in them where we could assess a person's risk right there with them and show them what the numbers were, and then show them what their risk was when we treated it adequately so they could see in real time what the difference was. And I think that's just going to continue and become more common and more prevalent. I know our structural cardiology colleagues have 3D apps that they can basically open up the heart, pull off the right ventricle or the left ventricle and show a patient exactly what the surgery is going to look like so that the patient's more engaged. They have the knowledge and ability to make informed consent and then to really engage and commit to their treatment. So I think we're going to see a lot of changes coming out, certainly much more automation with AI in being able to probably read studies quicker and more accurately so that it frees up time to have that one-on-one with the patient, because you still need that patient to practitioner interaction and to be able to interpret the AI recommendation not only for the patient, but also match that recommendation to the patient's needs and the patient's interests.
I remember those days where somebody has to go in the clinic to get their blood pressure checked, but now you can have that checked on with a wearable equipment on your arm. It will tell you how much pulse you have, how much blood pressure you have, rather than just depending on clinics and hospital visits. So the future really looks very bright, not only in the screening side of things, but also in the treatment itself.
For technology-minded people, electrophysiology is really a fascinating field. Implantable pacemakers and defibrillators, they communicate completely electronically, asynchronously with data storage information. Electrophysiology clinics can get reports when there are anomalies in heart rhythms, if there are any technical issues with the wires and cords. So anybody that likes any type of technology, that's just an amazing field. And as you alluded to, really has become virtual and can even sometimes do programming without the patient even being in the office suite.
The sky is the limit. Definitely, the sky is the limit. And I think the integration between nanotechnology and AI, as well as all the developments in imaging, are really going to revolutionize this field of cardiology. So if I was to go back to PSO and becoming a PA, maybe this is an area I would be really looking at very closely because of the amazing discoveries and technologies that are going on. And of course, seeing a difference that you in the patient's lives. So we're going to be concluding here. It was really great to hear from you. I'm so glad this issue is coming out. I can't wait to see it out there in public. Do you have any concluding remarks?
Just encourage PAs and other clinicians to read this, stay up to date on cardiovascular management, because it is going to be changing rapidly as we move forward. But the main point I would love to just say is that we can really make a difference and really treat patients and improve their lives. And that's the rewarding part of cardiology and the benefit of reading these articles.
Thank you so much, Dr. Dupamani. Indeed, that is the purpose for the PA Clinics Journal. Our goal in most of these series is to equip healthcare professionals with the knowledge and the tools and the new development so that we can give them more power in helping their patients. So thank you so much. It was great working with you on this series. Thank you.
Thank you so much for taking the time to speak with us today, and thank you to our listeners for joining us for this edition of the Clinics Review Articles podcast series. For an exclusive discount on the issue we discussed today, focusing on cardiology, visit us.elsevierhealth.com/expert. PA Clinics is available for individual print subscription with accompanying online access, as well as individual online-only access, and is also available on Elsevier's electronic platforms Clinical Key and Science Direct. For more information on this series and our nearly 65 other titles spanning all medical disciplines, visit info.theclinics.com. Be sure to follow us on Twitter at Clinics Reviews and subscribe to the Clinics Review Articles podcast wherever you get your podcasts. Thanks for listening.